Good afternoon, good day, everyone. We'll get started in a moment. Just let a few of our attendees come in. Okay, we'll get started. Welcome, everyone, and thank you for joining today's webinar. I'm Jim Huffman with the Integrated Benefits Institute, and I'll be moderating today's discussion. I'm joined by my teammate, Carole Bonner, who led this research project and will share key findings. We're very excited to be joined today by Tammy Fennessy, who is responsible for benefits at Dick's Sporting Goods. Welcome, Tammy. Could you tell us a bit about your role at Dick's and your career in employee benefits?
Sure, Jim. Thank you so much for having me. So yes, I've just recently joined Dick's Sporting Goods. I'm the director of benefits here and have been here for about 3 months now. Prior to that, I was at American Eagle Outfitters for over 9 years as led their benefits, and also spent a number of years in the retail or the restaurant industry in benefits. So all told, it's been probably about 16 to 17 years that I've been managing employee benefit programs. And I also am very passionate about population health management. It's something I'm pursuing my Master's of Applied Science in Population Health Management degree through Johns Hopkins. It's a passion project for me and something that I find I can apply to my daily work and the populations that I serve through my employers. So thank you for having me.
Well, fantastic. And congratulations, Tammy, on pursuing that further education, because it is a lifelong learning opportunity, but to do that plus a full-time job, plus responsibilities outside of work is no easy task. Congratulations.
Thank you.
Okay, we have 1 hour scheduled for today's session. We are recording and we'll share the link as well as Carole's slides to all who registered. Now, please take advantage of the chat feature and submit your questions. We've blocked time at the end for Q&A, but don't hesitate to drop a question or a comment at any time. Our topic today is the impact on workplace productivity that has resulted from delays in accessing medical care. We know that the pandemic had an incredible impact on access to routine medical care and preventive screenings. But Carole's research will demonstrate that the challenges to accessing care still exist and may be getting worse. So let's get started. Carole, I'll turn it over to you.
Okay, here we go. And welcome, everyone. Today, we will be discussing the trends and expenses linked to postponed medical care in the U.S. As Jim stated, due to the fear of contracting COVID and overwhelmed healthcare systems, many people delayed or avoided routine doctor visits and procedures during the pandemic. However, even before the pandemic, cost was a significant barrier to healthcare access, causing individuals to skip medications or ration them and forego mental health treatment. A study that IBI conducted last year found that individuals were still delaying care through 2022. It looked at delays in medical care due to cost, fear of contracting COVID, appointment availability. The study revealed that individuals with chronic conditions tended to avoid care at a higher rate. This makes sense because people with multiple chronic conditions had more reason to be concerned about getting COVID, and they require more care more frequently. Although these concerns are less prevalent now, financial strain remains. And so we need to monitor those who are still avoiding or delaying medical care due to inability to pay for it.
Thank you, Carol. It's been quite a journey from the March of 2020, when the pandemic was officially declared, until today. And hopefully many lessons that we've been able to learn from that period of time. Let's get into more of the details about your findings.
Okay, so IBI members felt it was important to keep an eye on these trends and their impact. I used National Health Interview Survey early release data to provide a quick update as to where we are today. So I analyzed 4 years of key indicators released by NHIS. Our analysis looks at the year-over-year trend and compares 2023 results to the height of the pandemic, which was 2021, as well as differences by demographic. We found that the percentages remain, let me close this, there we go, we found that the percentages remained within the margin of error over 4 years for people who are unable to afford necessary medical care. So it is, as you can see, 6.4 in 2023. And like I say, all of these numbers are within that margin of error. And we'll talk about a little later how this differs for some population segments. When we look at those who did not get prescribed medicine to save money, the rate decreased in 2021, but went up in 2023. Now, these are confounded, of course, by not getting medical care needed and hard to determine which is at play. However, this is a concerning number. Mental health care access has fluctuated. So you see these numbers going up and down. Although these two are within the margin of error, in 2022, it did go up to 4.8%, and then again in 2023 to 5.4. So this is an increase of 33% from the height of the pandemic.
Hey, Carol, it's really frustrating to see the trend on both the prescription medications and the mental health care. Both of those are so critical
Yes.
to the impact of both near-term and long-term health. And I would have assumed that they would have improved, but I guess what you're seeing in this early release data is that that's not the case. We're really going to have to focus on, can you drill down a little bit more, maybe demographics or
Yes.
other factors that we can look at?
Absolutely. So when we examine the demographics, we noticed that although the overall average remained the same between 2021 and 2023, some segments saw larger increases and of those who couldn't afford medical care. For example, females experienced a small increase while males saw a small decrease. Also, those aged 35 to 49, right here, had a significant increase of 8%. White and Black non-Hispanic saw a decrease, but other races, and this other races is Asian American, Indigenous, Native American, Pacific Islander, and other non-Hispanic races. So other races and Hispanic saw increases of 20 to 24%. Similarly, people with college degree or higher saw a big decrease, 18%. While some college was 5%, high school 12%. And those in the Midwest had a big decrease, 21%. Northeast decrease, but South had an increase. And this is medical care due to cost. We also look at mental health care, which is that 33% increase. And as you can see, there are some big differences by demographics. Look at that age 35 to 49, that's 53%. That's a big number. And other races, non-Hispanic, that's 66%. Also, high school diploma or lower is 61%. These are big differences. Midwest actually saw a decrease, not a decrease, a lower increase of 9%. And the others saw a big decrease, a big increase, I'm sorry. So Northeast is 43, West is 45.
Carole, I just want to highlight here that while we started talking about the pandemic, and we all know that people were not able to access a lot of routine care during the pandemic, now your update is focused post-pandemic, and cost is the barrier. And what we're looking at here in this far right column with mental health are the percentage of people by category who are not able to access mental health due to cost. So
this is the percent change from the height of the pandemic to mid 2023.
Okay, but all indications are from that graph that it's getting worse, not better.
Yes, absolutely.
Okay. And cost is cited by the respondent as the reason that they were not able to access the care.
Exactly.
Okay. Well, that's amazing. Let's I know you've got some statistics on productivity next.
Yes. So we have changes in absenteeism, and absenteeism as defined by NHIS is high absenteeism is those who miss more than 6 days. Okay, 6 days and more. I believe the average from a prior project is about 4.5 days. So this is considered high. Okay, so the number of those who miss more than 6 days year to year, it's 11.9 for 2020, significantly increased to 15.7 2021, then 17.7, and then went to 16.7. So that's a 6.4% increase from the height of the pandemic.
So a slight improvement in 23, but a statistically significant change 22 to 20 or 21 to 23 is what you're citing there.
Yes, yes.
Okay.
Absolutely. And so when we look at the demographics, you see that there are big differences. So it depends on where you fall. And of course, these are averages. So there was a decrease for those 35 to 49, decrease in high absenteeism. 18 to 34, a slight increase, but we have this big one for baby boomers, 15%. In terms of race and ethnicity, we have 7% for white non-Hispanic. We had a decrease for Black non-Hispanic and for Hispanics. Big decrease for Hispanics. And a huge difference for other races. College degree and more, a big difference, 35%. And high school diploma lower, a decrease of 7%. And the Midwest, a decrease of 7%. But this Northeast is a spike, 26%. West, 9%. South, -1%. So it's very nuanced. We can look at the overall average, but in order to determine who needs help, we need to look at the demographics. And then we have disability status. And this there's no change here. They're all within the margin of error, 9.2, which is good. But then when we look at the demographics, this is not as varied as the others. However, people, again, the females went up 4%, males went down 2%. 18 to 34 spiked 31%. And disability within this frame is people who have the inability or limited ability to see, hear, speak, move, cognition. Oh gosh, I've forgotten the other one. But if they indicated that they had the inability or limited ability, they were considered to have a disability. All right, other races went way down. Hispanic went up a little. And then some college went up a little. Northeast went down. Actually, everybody did good except the West. So we wanted to quickly give a sense of what the economic burden of all this is. There is a relationship between education, income, workforce that significantly impacts people's health outcomes and behaviors, which in turn impacts the employer. So we identified distinct patterns and we categorized individuals based on education. It is more complicated than that, but we wanted to give a quick conservative estimate. So we took wages from the Bureau of Labor Statistics, and we look at that high absenteeism, and we look at how many. And so we have educational attainment, high school diploma or less, median wage for 6 days, again, this is very conservative, is $6.99 average. Some college is $9.07, and bachelor's degree or higher is $13.78. And we take that number, we look at how many are in that group and the percentage, and we estimate nationally what that would cost. So the cumulative sum is $26 million nationally, which is an average of 1,021 per person. So these are not including other opportunity costs such as presenteeism, replacement cost, or there's a whole way to calculate how much money is lost because of absenteeism or disability, but they are all generally a function of the wages. So we thought we'd provide that for you.
Carole, I think this is really important because I think it's intuitive to know that when somebody misses work, there's an impact of productivity. But what you've been able to do here is to really quantify that and order of magnitude, not precise, but really give our audience an order of magnitude that when somebody is missing work because of one of these situations, there is a real financial impact to the organization. Set aside the impact to the individual and their health and their family, but to quantify the productivity impact, I think, is something that many employers, sponsors are very interested in, kind of ballparking what that figure looks like when this type of situation happens.
Absolutely.
Yeah, great work. All right, let me check the chat just to see if anything came in while you were going through your slides. Okay, I don't see anything there. Okay, Carole, thank you. That was great. I know you had a ton of information to distill down, and I think it was really well done to be able to get that down to about 15 or 20 minutes of conversation or information. And again, we'll have those slides available to everybody after today's broadcast, and you'll be able to look through those in a little bit more detail.
And the report has been released and it has more detail.
Fantastic. Thanks for that reminder. Okay, Tammy, let me turn to you now. And Carole just shared some really concerning stats about people who've not received their care throughout the pandemic and now post-pandemic. What's your initial reaction and thought about this?
Well, I would definitely say I think my initial reaction is probably not one of immense surprise, probably one more, I hate to say it, more of kind of disgust and disappointment with our healthcare ecosystem. I would venture to say probably a lot of my colleagues, kind of would feel the same way. I mean, most of us know that, healthcare, overall, it's so costly and it's done so much damage even prior to the pandemic occurring in regards to, to people having to claim bankruptcy. I think the numbers are around 60% when you go out and you look at the American Bankruptcy Institute of people who are, bankrupt because of medical debt. There's a lot of fear of the system, not knowing, exactly how much things are going to cost when you enter. Transparency is not, it's not present yet. Thankfully, maybe we're starting to go down that road, but it's very difficult for people to navigate and know what they're in for when they walk into a hospital or into, any kind of primary care setting. So I think, as I look at this, I mean, when I'm thinking about what people are going through, that we've got, 41% of adults, the Kaiser Family Foundation shared 41% of adults have medical and or dental debt. Over half of them only owe about $2,500 or less, but the vast majority of these people are falling into, they're in marginalized populations. Now and I mean, it impacts females more greatly, Black Americans, Hispanics, those with lower income levels, those with lower education levels, those that are uninsured. So it's really, it's not something that's new, I think is my point. It's like, this has been something, yes, the pandemic had a negative effect for sure. And I think, but that coupled with what was already happening prior to the pandemic, I'm not overwhelmingly shocked that this is happening now. And I think the other things that we're seeing in the market is, and most are aware, there's a huge nurse shortage. There's been a lot of nurses that have left the field and, or doing what they do, in a different way. And it's causing definite issues, I think, in the system. I mean, people aren't able to get appointments as quickly. We're also seeing a lot of, mental health practitioners that decided to leave the field and pursue other ways of earning money, or maybe even I've heard like even pop up yoga shops, or what have you. It's something that's less stressful. And those that are there, they a lot of them can't even take on additional patients. So I think there's a lot going on in our healthcare ecosystem that really either needs to be recreated, rethought out, or at least ideated about to make a difference.
Yeah, it's just scary because I think you're right. This is not a new issue. The pandemic kind of magnified it. I think employers, the suppliers, the carriers that we all work with, they're seeing it. But now it's really, and I think Carole had some really compelling statistics on the demographic breakdown there. And I mean, I've looked at this now for a few weeks as we've been preparing for this, but I'm still really in shock about the mental health and how every one of those categories is moving in the wrong direction. What stood out to you?
Quite a bit. Yeah, so thank you for that, Carole. I did take some notes on this because as I was looking through, it is really mind-boggling. It definitely is. I think even thinking about like the statistics around productivity and missing days at work, it's very interesting to me. I mean, this age group of the 18 to 34-year-olds, I mean, yes. 31%, increase in disability status. That's, I mean, obviously as an employer, I mean, we're going to see that out, all over the place. It's not just going to be in the medical claims and RX claims, it's in disability claims, and then it lends into long-term disability. So from a productivity standpoint, it's an enormous thing. And obviously this is a younger population that you would hope would be on the healthier side. So it's really, I think, pretty alarming. And then to see, people with, college degree or higher, 35% with the 6+ work days missed. The other one that really stood out at me is the other non-Hispanic races, that 40% or more with 6 days or more missed. And it's really, it feels like it's hitting pockets of people that we haven't even really fully explored or vetted, in the past, which is most definitely alarming. And again, and I agree with you, Jim. I mean, what's happening in the mental health space, it is really very concerning. I think, like I said before, a lot of the practitioners have left this space. I think we really need to lean in and figure out how to solve this issue. And I know a lot of employers have, implemented, mental health first aid in their workplaces. They're trying to eliminate stigma. But if you don't have the network and, and people that you can actually send your people or, guide them to go to, that is a real issue. And this isn't going to go away. I mean, most of us also know that when you have, mental health conditions coupled with one or more chronic conditions, it has an exponential impact on your medical claim costs. So it's from a financial standpoint and a human standpoint. I feel like it has to become more of a priority for us. And one of the things that is frustrating right now in regards to like employee assistance programs and the networks that have been built out over the years, I found out recently, I was actually listening to NPR's probably a couple months ago, and they had had a talk about the networks that exist right now. The onus has always been put on the practitioners to reach back out to the medical insurance companies or the EAP and let them know I'm no longer practicing. That's kind of an oxymoron.
Right.
I think it's backwards. So, I mean, what practitioner would honestly do that?
Right.
So it becomes, really a burden on the patient. When they're making their rounds, we're also hearing, well, if they call us and let us know that mental health practitioner is no longer a network, we'll take them out. It doesn't make sense. I think we need to obviously really rethink that to figure out who's still here, who's still willing to practice. And also, I think, I think we really need to think about leveraging some of these virtual capabilities in a much broader sense.
Yeah. There are a limited number of clinicians and practitioners in this country.
Yes.
Right? We can't just produce them overnight. There's medical school training that they have to go through, and before they can come into practice. So even though you're right, a lot of solutions have come up over the last 3 or 4 years, 5 years in this mental health EAP or new EAP, as I think some people refer to it.
Yeah.
And it's great for visibility. And, I think we're starting to break down some of the stigma that has existed around accessing mental health care. But again, there's only so many clinicians at the end of the day. And, if they start to limit their practice or leave practice, as happened in the nursing profession and even physician practices have been closing, we get fewer and fewer. And that's moving in the wrong direction. So I think you're right. We've got to ideate on new solutions and new ways to address this.
Yeah, I totally agree.
So Tammy,
I'm sorry, Jim. One of the things that is in the report that I didn't present is that there is a greater need for mental health. More people have depression and anxiety, but also more people are accessing counseling. It's just that the need is outpacing the staffing, and the money.
Yes.
Right.
Yes.
So Tammy, with your employer benefit manager hat on, what can we do? You have so many, limited things you can do, but what are some of your thoughts on addressing some of these gaps that we've talked about today?
So I think for years, my passion has been around trying to remove barriers to care. And obviously that does come out of plan designing and how you price it. I would encourage any employers that are out there right now to embrace innovation, kind of be willing to be the guinea pig because it may just work out. There's so many innovative companies out there right now. And I think we really do need to start, thinking outside the box and really embracing concepts like, advanced primary care, baking mental health into every visit that someone has in the doctor's office. I think right now, I think it's just something that the CDC, or it might be CMS, has required it of accountable health communities to be asking the social determinants of health types of questions. And I know we're going to we'll talk about that more later, but there have to be ways that we can get ahead of this and get upstream to help people before they get too far on their health journey, or where it starts to create other issues for them. The solutions that there's, like I said, there's a lot of innovative ones out there. I will say, not trying to plug anything, but there are some amazing interventions happening on your phone. And I know people have app fatigue, but there's literally like an app out right now that will do all of your preventive exams and help you to connect with doctors. And it's pretty remarkable. How technology is being leveraged in these spaces in a way that they never have been able to leverage it before. So I would encourage anyone to go back to the conferences, start meet with people, talk with with them about what they've been doing throughout this pandemic. Because trust me, a lot of these companies have not been sitting idle. But they are waiting for, employers that are willing to take the leap and check them out. I guess I would also say, keep your plan designs that you had in place. When the CARES Act came out, I believe it was, they opened up the threshold for people that are on high deductible health plans to access telemedicine at no cost. If you reared back from that and started charging again for any reason, I would strongly encourage you to go back. It's the least costly way for people to get care. It honestly is in my opinion, it's a win-win financially and humanistically. So, just opening it up for primary specialists like dermatology, as well as mental and behavioral health. And this is a limited service that people can get at no cost, so I think it just really, like I was saying, really leveraging those virtual capabilities, I think are really key nowadays. You have hospitals closing down all over the country in rural settings. People just, the ability to access care by car is even a challenge, in a lot of cases, or like I said, or doctors just they don't have appointments available. So you really do have to, I think, build trust within your community, your population that you're serving. Let them know this is, something that, we are trusting. We're trying our best to give them, different channels that they can try to access care in the privacy of their own home.
I think you make a lot of great points there. One that really ties back to what Carole has shared today is cost. So if sponsors, employers did change their design on telehealth under the CARES Act, now's the time to go back and address that, or at least look at it. Easy for me to say to change it, but we know based on the research that Carole has done that cost is a barrier, not only for the prescription drugs and the mental health, but the primary care services as well. And if you do have a virtual option available and people can use that at low to no cost, that's a good thing. Removing that barrier and opening that up for them is a good thing. There are other issues around the medical record and the continuity of the care and the relationship, but a cost barrier is something that really should be looked at and determined, is it necessary?
Right. Well, and I also would say, Jim, I think, employers really need to push vendors to make sure that, things are offered up in multiple languages. I mean, when you're seeing, what's happening with, the Hispanic populations, I mean, at least do it in English and Spanish, and really pushing them to make navigation easier. And, like any medical insurance vendor, if you're offering up telemedicine at 100%, taking on the cost as an employer and offering these no-cost benefits, that might even be like, digital musculoskeletal or a pre-diabetes program or a hypertension program. They should be front and center on your medical insurance member-facing platform. Your employee, all of your employees should be so aware, hyper aware, that they have these resources available to them. And many times they get buried and are difficult to find. So I think navigation is really key right now to make sure that people can use these programs. I mean, we're all putting them in, we have for years.
Right.
But a lot of employers are starting to look at it and say, well, I'm not getting the ROI out of this. I guess I would encourage you not to give up, but to try something different in regards to communicating it, at least.
Yeah, I want to pick up on the social the apps that you mentioned as well, because Carole has another report, her mental health report, which we'll be doing another webinar on shortly. But Carole, you had a statistic in there about the people who used an app for behavioral health, and a really high favorability. People felt that it was helpful. But say a little bit more about that. Carole.
Yes, I'm sorry. I'm sorry. Absolutely. People who are accessing these apps are finding benefits. And when you talk about ROI, it's a small cost compared to the gains in productivity. The employee doesn't have to miss work, doesn't have to travel an hour. They can pick up the app, and it can be preventative too. So yes.
Hey, Tammy, a question did come in on the topic of free that we just had the discussion on, and someone posted it may be difficult to make virtual free in an HSA environment.
But the regulations, I believe, allow us to do it through 2025.
Okay, that's what my thought was. We can look into that after. And then another comment that it's kind of late breaking, but let's see if there's any thought here. There was a report that came out, I think, earlier this week about the pre-diabetes programs not working. I mean, they basically called out those programs and said there was only one that I think had demonstrated a real impact. So, any thoughts on what do you think about that? These programs not paying off?
I think it's interesting. I think that, there's a lot of programs out there, and a lot of them have been out there for quite some time. I think working with your contract to make sure that they can't keep somebody in the program perpetually by maybe stepping on a scale twice a month might be an issue, driving down ROI. I do think too that there again are just some other innovative solutions around pre-diabetes and and I know obviously obesity management that need to be explored. I don't know, over the years
I'm sorry. I think there needs to be research around why they're ineffective. I don't think you should throw away the baby with the bathwater. Look at the programs and see what's happening. Are you not communicating it to people? Are you not incorporating nudges to eat correctly? Dig deeper, but don't just throw it away because of the research.
I agree with you. I think, in a lot of cases, we really need to work with the vendors very closely and not just say, okay, well, this is your product and we're not going to give you our feedback and help you make it better. And what I was about to say was when I've looked at, my population that is in the pre-diabetic space, I often heard they didn't want to be in a program. that they wanted nutritional nudges, that they want to know, like, how can I get rid of my GI? It's like, it's really, it's not simple. It's very complicated. And I think, these vendors, they're trying, to put out a solution that'll be engaging. People can join groups, they can learn about, their diet, they hopefully can get exercise or stepping on a scale. And maybe that's too much. Maybe, maybe it's too much all at once, maybe they have to step back and do some, kind of smaller steps to get there. But again, I wouldn't run away from these. I would just be I would manage them closely and work with them to see if they're willing to make changes, see what parts of the program they're seeing like the highest clicks on or engagement with, and capitalize on those and know that the other parts of the program aren't having those types of results. So they, hopefully will, take your feedback and make changes. If they won't, trust me, there's enough point solutions out there. Someone will.
Tammy, I want to bring us back to something you mentioned and really is at the core of what Carole has shared today around what I'll call the social determinants of health, right? So the diversity of a workforce and diversity any way you want to look at it. We know that employers are looking at things through that lens. We know that suppliers, vendors are starting to look at things through that lens. What are your thoughts? What's your experience with SDOH and how can it help as you drill down into data?
Yeah, I think there's a lot of ways that you can look at your data to try to gain insights and try to really lean into your marginalized pockets in your population. And, when you look at, I think they've started kind of rebranding, SDOH as social drivers of health, which I like that a little bit better than determinants. Because it does make sense to me. But I think too, when you're looking at the SDOH, you also, it's one part of the equity equation, right? So I think, when we think about social drivers, we're thinking of things like, healthcare access and quality, economic stability. So like unemployment or income level, we're looking at education, a person's community and how their social network, their neighborhood, their built environment. And the built environment is actually, it's an interesting time period because we have a lot of cities, some big cities that were built in the late 40s that their infrastructure is blowing up right now. I would encourage urban planners to look at this and say, wow, we have an opportunity. We have a huge opportunity to make our cities more walkable, to give people access to grocery stores, to not be so daggone reliant on transportation. So I think there's a lot of, different things we need to be looking at in this space. I do think it's going to take an immense amount of collaboration. I think it's very important that, like, when we do look at SDOH, that we realize, only 20% of people's health is directly related to the health system and the access to it. And I'm sure many of you on this call have heard this, but, it's behaviors, it's the environment, it's the socioeconomic factors, that play into this that are really driving people's overall health. So, I mean, you can't just look at the healthcare system and say, you need to fix this. It's going to take us all. It's the collective impact of all of us that's going to make a difference. And when I speak of all of us, I mean, I'm speaking of, first of all, the people in the community, like really, really engage your population, get to know what their needs are, talk to them, find out what, where we're missing it. And every employer's population is different. You can't, don't make broad sweeping assumptions without getting them engaged and making them part of the process. I think that is really probably the biggest key to getting these things fixed. But on a broader scale, I mean, we need to engage, not only just the hospital systems, but public health, coalitions, and, like I referred to before, urban planners. You're talking about, nonprofit groups, community-based organizations, leaning on going to your medical insurance company and asking them, what are they doing? You know, how are they showing up in the community, and what programs can you leverage for your employee base in partnership with them to make sure that they realize those programs are there? And there's some of these insurance companies that are they're giving people food for 6 months if they realize that they're food insecure.
Mhm.
You know, we need to bring these things to life. And you might be aware of like the website Aunt Bertha.
Mhm.
You know, and I mean, and I think there's a different name for it now. I think it's findhelp.org. But a lot of insurance companies have adopted that. And I mean, it is such an incredible resource for community-based organizations. And asking your insurance company, how are you closing that loop? I mean, if you're just guiding someone to a link on a website, that's really not enough.
Right.
You need to make sure that they're, you know, taking it that extra mile. But I'm very passionate about social drivers of health, and definitely looking at all plans from an equity lens. I think, you know, employers for far too long have had plan designs that favor those who make more. So I think, you know, even just stepping back and taking a look at all of those policies, historical policies that have been in place forever, and asking why
Mhm.
is really important right now, and can financially benefit your people.
Tammy, great stuff. You mentioned the community, and I've seen a couple of examples over the years where employers in a community come together and really collaborate and partner, because they are community citizens, right? They're not only employers, but you know, they're doing lots of things in their communities. And if there are opportunities for employers in markets to think about that, you know, it's so much more powerful when people can come together and resources can come together to do things together and for the benefit of that community. And it doesn't have to be a Dick's Sporting Goods or, you know, a bank in a community. It has to be all. We can't do this ourselves. And I think that's one thing that you've kind of highlighted, the opportunity to think outside of the four walls of the company.
Yes.
And you can even take that further to that collaboration and partnership amongst employers and others. You know, hospital system. Every big city has multiple hospital systems, hopefully, if it hasn't consolidated. They can come together as a community citizen to do things as well.
Absolutely. Well, and I mean, to your point, nonprofit hospitals have to do a community health needs assessment every 3 years to get their, you know, their Medicare reimbursements. So it's really, you can just go online and look up, you know, the number one hospital that your people are going to. If it's a nonprofit, they may have a plan all together that you can see what they're trying to do in the community. Saying it's really, yeah, just tapping into those resources that are out there.
Okay, there's one other question that I was thinking through as we were talking, and I just want to get your reaction to it, Tammy. You know, I think many employers look at high cost claimants, those people, whatever their trigger is, 75,000, 100,000, but they've got visibility to those high cost claimants. What we're talking about today are people at the other end of that continuum who may not have any claims cost until they become a high cost claimant, right? Because they're avoiding or missing the care that they need. So in your experience and what you know about the industry, you know, are employers or their carrier partners looking at that other group to say, if we've got somebody 40 years of age, maybe we know that they have, or 40 age cohort, maybe not the individual, but the cohort of 40-year-olds in the organization without claim dollars. That's a problem.
It is a big problem. Yeah, absolutely. And to your point, I don't think most employers have really taken that number very, very seriously in regards to building out a strategy around it. And every employer that is, as you know, self-insured, fully insured, they hear the utilization numbers. They generally don't hear them, but one time a year when the vendor comes on site and tells them what their claims looked like from the prior year, which is about 4.5 months probably after the plan year even ended. So again, we're chasing this, and you know, to the earlier point of trying to get upstream, trying to really prioritize prevention so that we can make our populations healthier. These are the people we have to be looking at, and they most definitely are. You know, we need to be looking at our data and saying, okay, how many people How many visits are people having? You know, what percentage of my population is even seeing a doctor, to your point? Take that number, that percentage of people, work with either your, your medical insurance, vendor, or if you think, hopefully you have an analytics platform by now that you can dig into, or work with your broker or consultant to find out, like what portion of my population. You don't have to go down to names, but I mean, out of those non-utilizers, how are they broken out? Like what parts of the country are they in? What age groups are they in? I think most of us know by now, like once you start getting around your 40s, things kind of start going the other direction. If you have people not going to the doctor and they're 40 or over, they're paying for their medical insurance, but they're not accessing anything. What is the harm in sending them a prevention schedule? Or just alerting them to the fact that, hey, are you like, here are the rules of the road. Go in and make your appointment and tell your doctor you want them to do only what's 100% covered under the preventive schedule. If they want another appointment, that's another appointment. But get your primary care exam. Like just make at least that step for yourself. And if you're seeing non-utilizers that are, in the millennial and the Gen Z space, we all know mental health is huge in that area. Or, look at your male population. Suicide rates are off the charts. Being able to engage these different populations in meaningful ways, I think, is probably what's most important. Coming up with strategies that make sense, that will resonate with the populations that you're talking to, but getting them engaged is a win-win for everyone.
Absolutely. Okay, we've got just a couple of minutes left. Let me pause here. We'll check the chat to see if we have any questions coming in. I do see one. Can we please link the report? Yes, when we send out the recording and Carole's slides, there will be a link. The report is available to employer members of IBI. If you're not a member, it's a very simple step. You can just put in your contact information on our website and give it 24 hours to activate, and then you'll be a member and you'll have access to that information. There's another comment. I don't think it's a question, but I think it's a really good one that Pamela Hannon put in. Understand the ROI concern, but employers provide life and other benefits that do not have an ROI. Sometimes providing a service has more than financial benefits. And Pam, I think it's a great comment because there are things that sponsors do because it's the right thing to do. And it's whether it's financial protection, health, mental health, physical health. But Tammy, I don't know if you have a thought on that as well.
Oh, I definitely agree. Yeah, some things are there just to give people, financial security, make them, less stressed. And if someone's going to eat healthier, but it doesn't take off any pounds, they're probably still feeling better.
Right. Okay, well, I think we are up against the time. I don't see any more questions coming in. It's been a great conversation. Carole, thank you for the great work that you've done to update everyone on this really important topic. And Tammy, thank you. Your perspectives and your passion for this really has come through in this conversation. And I hope you've helped some people to see the opportunity to go after some of these things and really look at the details and the opportunities. I want to thank everyone who's joined today. And again, we'll be sending out an email shortly that will have the link to the recording, the link to the report, and opportunity to sign up for that, and then Carole's slides. Thank you all again, and have a great day.
Thank you.
Thank you.